As a small boy, I remember walking through the streets of Asmara with my mother and seeing posters about a disease called smallpox. I remember hearing about an institution called the World Health Organization that was ridding the world of its terrifying disease, one vaccination at a time. Until it was eradicated, smallpox had plagued humanity for thousands of years, killing 300 million people in the 20th century alone. Although 40 years have passed, the legacy of smallpox eradication lives on in the strategies and tools we use to fight emerging epidemic diseases. Smallpox also laid the foundation for national childhood immunization programs worldwide, which are critical to primary health care and the movement for universal health coverage. But smallpox wasn't just a public health triumph, it was also a political triumph. At the height of the Cold War, the Soviet Union and the United States of America joined forces to conquer a common enemy. They recognized that viruses do not respect nations or ideologies. The same solidarity is needed now more than ever to defeat COVID-19. The success of smallpox eradication shows us what's possible and has allowed us to dream of another major public health achievement, the eradication of polio. We have brought polio to the brink of eradication, but we are not there yet. We must continue with even greater commitment and determination until we finish the job. The last mile is the hardest mile. And let us remember, the smallpox vaccine was discovered in 1796, but it took more than 200 years to achieve eradication. The lesson is clear. Technology is not enough. The best vaccines in the world do not help us if people don't receive them. We must invest in immunization programs, public health communication, and strong primary health care. That's the only way to achieve health for all, protect people from devastating outbreaks, and build a healthier, safer, fairer world. I thank you.
I'm David Heymann, and along with Joel Breman and Dan Bausch, have organized this symposium on smallpox. The symposium marks the 40th anniversary of the eradication of smallpox, a disease that as recently as 1967 caused an estimated 2.7 million deaths per year. The success of the eradication program clearly showed the cost-benefit of vaccination and led to the establishment of the expanded program on immunizations as a means of getting childhood vaccination to all children. There were many lessons learned from smallpox eradication, and the first speaker is Bill Foege. Many of you will know that Bill innovated the ring vaccination strategy during a shortage of smallpox vaccine, and it became the mainstay of the smallpox eradication program, replacing mass vaccination. And ring vaccination remains a strategy for use of vaccines in outbreak control today for infections such as Ebola. And we will hear from Bill the lessons learned from eradication. Jose Esparza will then speak about the origins of the smallpox vaccine as he tries to set the record straight on where the vaccinia virus originated. And Rosamund Lewis will discuss the risks and benefits of having retained smallpox virus in 2 laboratories, one in Russia and one in the US. And finally, Annie Rimoin and Chikwe Hikwezu will speak about human monkeypox and its changing epidemiology in the absence of smallpox vaccination, a vaccination that protects against human monkeypox. One lesson that I've learned from smallpox eradication is the importance of using tools that are available at present to maximally control infectious diseases and not to wait for additional tools that may be promised or in the pipeline. The decision to eradicate smallpox was based on a risk-benefit analysis of a vaccine that caused 1 death per million persons vaccinated. Smallpox vaccine has serious side effects and sequelae. Yet this imperfect tool was deployed, and smallpox was declared eradicated in 1980. 1 year later, in 1981, HIV was first identified, and in 1984, a military recruit in the US was vaccinated against smallpox and developed generalized vaccinia. Later, as he developed signs and symptoms of AIDS, he was diagnosed as HIV positive. The vaccine presumed to have been an AIDS-defining event, and 6 months later, he died. With the HIV prevalence in the world today, the vaccine used to eradicate smallpox could not be used safely. Smallpox eradication took advantage of a window of opportunity that closed as HIV became endemic throughout the world. And as you will hear from Rosamund, there are now second-generation smallpox vaccines that are safe for use in HIV-infected persons. It's now my privilege to cede the platform to Bill Foege.
Okay. Hello, I'm Bill Foege. I worked in smallpox eradication a half century ago, and I'm grateful that you allow me to be part of this meeting to talk about that time. 20 years ago, I made rounds at a hospital in Botswana, and every patient, I believe, had AIDS. They never used that word. Instead, they introduced each patient with, this person has cancer, this person is malnourished, this person has tuberculosis, but they never used the word AIDS. After rounds, we went into a room and I asked the medical director who had taken us around, how do you get yourself up every day to do this? And how do you protect your emotional state? And then I worried about having asked the question because he just sat there and looked at me. And I was trying to figure out how to get out of this predicament when suddenly tears rolled down his face. And he said, I've never told anyone this before, but I was born one of 4 sons. My 3 brothers have died of AIDS. I don't have a choice. That's the way it was in smallpox. When we got started in smallpox, we came to a point where we did not have a choice. We could see the end, and we could not leave it. Julius Richmond, who was Surgeon General, was once asked, how is it that the CDC group, starting in the 1960s, was able to eradicate smallpox from 20 countries of West and Central Africa in 3 years and 6 months? And Julius Richmond said, they were all so young, they didn't know they couldn't do it. And that's what happened. We were so young. And we were so young that we've had a long time to learn lessons. It's an interesting time to talk about the lessons learned from smallpox, because I talk about these lessons to many groups. But then I say, with all those lessons, every lesson was violated with coronavirus in the United States. So lessons learned can be unlearned. And we're back to learning rather than being learned. We have come up with some lessons, but we've also come up with some truisms. In the last 50 years, one of the truisms that I've come to is that all of public health is global public health, because every spot in the world is both local and global. So no matter where you're working in public health, you're working in global public health. A second truism, no matter what you're doing, we all share a common objective, and it can be put in 3 words: global health equity. Take any of those 3 words away, you don't have the same objective. Add 200 words and it doesn't improve it. Global health equity is the objective we're after. There's a third truism. Many years ago, I was speaking to state health officers, and during the question period, a state health officer asked me the question, what's the difference in the philosophy behind public health and medicine? And I said, my understanding is that the philosophy behind science is to break down the walls of ignorance, to find truth. The philosophy behind medicine is to use that truth for every patient that you see. The philosophy behind public health is to use that truth for everyone. Therefore, the bottom line philosophy becomes one of social justice. And when I said that, a man jumped up. His name was Dr. Cannon. He was the health officer of Rhode Island. He said, I've been in public health for 50 years. I've never heard that before, but I know intuitively that that's true. He said, don't ever give a talk again without mentioning that. Other people should not have to go 50 years before they hear that. But there's a fourth truism, and that is that the actual power of science is not in its existence. The actual power comes in its use, in the application of that science. And so we see that smallpox vaccine had been around for 160 years, but it was the application of that information on a global basis that allowed for eradication. And one more truism, a fifth truism that I've come to understand, and that is no matter what we do in science, we really are supported by a three-legged foundation. The first is, of course, science. People outside of science think we really know things, and we don't. Science is based on uncertainty, not certainty. And Richard Feynman said, certainty is the Achilles heel of science. Then Huxley defined science once as common sense at its best. So that's a good place to start. Common sense at its best, but it's not truth. It's a way of finding truth. It's a way of trying to get to truth. But then Will Durant said, science is improved if you add to it art, because then you have the creativity of art and you have creative common sense at its best. And that's a wonderful description. He says the first person we know in history by name was Imhotep, the Egyptian, who was a physician and an artist. He designed and built the step pyramid. And he said, that's something to aspire to no matter where you are in history, to be both an artist and a scientist. But there's a third leg to this, and it comes from Roger Bacon, 700 years ago. He was asked to do a report on science for the Pope. And he ended up with 3 lessons. I'll mention only one of them. The third lesson was, science has no moral compass. So you have to have scientists with a moral compass. And that then leads you to creative, moral common sense at its best. And that, in just a short sentence, gives us the foundation, the understanding of what we should be doing in science, what we tried to do in smallpox. There's some key lessons, though, from the smallpox program, in addition to these truisms. And the first one is, it did not happen by chance. Stephen Hawking says in his book, A Short History of Time, that the history of science is the gradual realization that things do not happen in an arbitrary fashion. It's a cause and effect world. And we oftentimes get confused on what the causes are and what the effects are, but that's where we should start, with the knowledge that this is a cause and effect world, and smallpox disappeared because of a plan to make it disappear. It's not a magical world where it just disappeared on its own. It required countries around the world. It required global agencies, bilateral agencies. It required non-government organizations. It required hundreds of thousands of people on the ground. And it required governments agreeing to do this. A second lesson from smallpox eradication: seek the truth. You simply can't do anything about a disease problem if you don't know the truth. And it's interesting how resistant we often are to the truth. We don't want to know the truth. And with the COVID-19 pandemic in the United States, we have trouble getting the truth. Every day, people put out different messages. Know the truth. In October of 1973, when we did our first village search in India, We did it during the low period of transmission for smallpox, and we thought what we were doing is trying to develop a system. We didn't expect to find much smallpox. But in 6 days' time, those searchers in just 2 states, Bihar and Uttar Pradesh, found 10,000 new cases. We were totally overwhelmed. And there were people who said, don't ever do this again, because it makes us look bad. Well, of course, we had to do it again because this was the best surveillance system we'd ever had for smallpox. And so seek the truth. And to know the truth, you have to have a good surveillance system. A surveillance system that is getting the right numerators, the right denominators, and the right information to interpret those. In October of 1973, as we then went to the second search and third search and so forth, we kept improving every month. So the first search was fairly haphazard. We would talk to a few school teachers, to the village leaders, to some students, but every month we got better until finally we were going door to door, house to house. And then that wasn't enough. We did secondary surveillance systems in markets. We did tertiary surveillance systems going to places where we expected smallpox to be found. So it was always trying to improve on what we knew and then feeding back that information to the people providing the information and to everyone who needed it in order to do something in the program. The third lesson was you have to do evaluation and continuous improvement. And this improvement was seen in all phases of the smallpox program, from developing and making the vaccine to right what we did in a village, from jet injectors to bifurcated needles, and forms to ensure that people were doing the things that we needed to have done. And one of the most important ways of improving was the monthly meetings in endemic states in India, where people would get together and say, this is what worked in the past month. And we would change tactics every month in order to build on those lessons. A fourth lesson, coalitions are required. There's no way to do this without a coalition. Gandhi once said we should seek interdependence the same way we seek self-reliance. And then he added in a soft voice, because there's no alternative. We can't do things alone, so we have to build coalitions. And the best coalitions are the ones that are built on trust. Trust is really the glue that holds together a coalition. And the lesson we learned is an effective coalition starts with the last mile. If you define the last mile, everyone knows what they've signed up for. And then you go back and ask, what's the next step to get there? A fifth lesson, avoid certainty. I already mentioned that certainty is the Achilles heel of science, but Feynman once gave an illustration that makes this so perfectly clear. He was shaving one day, and all of a sudden it struck him that physicists, and this is about as certain a science as we ever find is physics, physicists had been incorrect forever when they explained why left and right were reversed in the mirror, because he said if that was true, top and bottom would be reversed. And all of a sudden, he started thinking this through again, and over a period of time, he finally figured out what happens with physics when you look in a mirror, and it's not what had been given for many centuries. So avoid certainty. When we started in 1966, 1967, we were so certain that you had to reach herd immunity in the largest areas possible, which is why we did mass vaccination. And then we discovered the first part of the strategy, mass vaccination, could be dropped, and we could concentrate on finding the virus. And so certainty held us back initially. A sixth lesson, political will is needed. And we all realize this country by country, you had to get the political leaders to agree to this. And I always said it was like a religious conversion. There was a day when suddenly they saw this could be done. But more important, they saw this could be done during their time in office if they actually supported it. This turned out to be key in India when the Minister of Health of India said, we don't need all these outsiders. And I agreed with him totally. You don't. I said, the difference will be if you have all the outsiders, you might be able to get rid of smallpox while you're still minister. And that just changed everything, that suddenly you had political will. Then one of the best lessons I think we learned was the best decisions are based on the best science, but the best results are based on the best management. And so smallpox eradication really turned out to be a management victory more than a science victory. The science had been there for a long time. The eighth lesson that I'll mention is tenacity, to never give up. Tenacity doesn't always win, but it's the only thing that does win. And when I think of the people in the field and smallpox eradication, I mean, tenacity really did demonstrate what they were doing. A ninth lesson, communications. This is the nervous system of any program. You have to get the right information in and you have to give the right information out. The 10th lesson, respect culture. The criterion for civilization turns out to be how people treat each other. It becomes the way you measure a nation as being civilized, a political party, a school, an individual, how people treat each other. And this becomes an important lesson in any global health work. The 11th lesson, global efforts are possible. There are a lot of people that think this is a waste of time to try to do things on a global level, but they are possible. And with smallpox, we find that it becomes a surrogate for an alien invasion. See, Will Durant said the world will not get together unless it fears an alien invasion. Well, we have surrogates. Smallpox is one. Global warming is another one. AIDS is another one. Coronavirus is another one. And we have to learn how to exploit these surrogates so that they lead to peace and the ability for countries to work together. The last lesson I'll mention is humility, that things can go wrong and do go wrong, and that we have to simply be humble that there are many things we don't know. We're learning as we go. And finally, what does this mean for the future? Well, I think it means think globally. Never again should we allow politicians to withdraw from the global community, whether it's for coronavirus or for global warming or nuclear safety. We should not let politicians take us out of the global community. Number two, make more of these surrogates, health surrogates for an alien invasion. Use this as a tool for improving what happens in the world. And third, health workers need to embrace the political scene. It was one of my real shortcomings early in my career that I did not understand the political scene. And I just assumed if public health people come up with the right definitions and the right suggestions, the political people will follow. It doesn't work that way. We have to know more about political science, which leads to my last lesson that I will mention. Some of you people who are listening today should consider going into politics. It's much more efficient to put public health people into political situations than to try to train every politician. Thank you.
Many thanks for the opportunity to participate in this important symposium to commemorate the 40th anniversary of the eradication of the smallpox. What I will do now, on behalf of my colleagues, is to present some results from our ongoing investigations regarding the historical origin and evolution of the smallpox vaccine, much of which is still work in progress. The beginning of the global eradication of the smallpox may have started as early as in 1801, when Edward Jenner prophesied in his book entitled Origin of the Vaccine Inoculation that the annihilation of the smallpox, the most dreadful scourge of the human species, must be the final result of this practice. And of course, Jenner was referring to the practice of vaccination. 3 years before, in 1798, Jenner has published his famous book, The Inquiry, describing how the inoculation of the cowpox, a mild disease of cows, protected humans against the more severe disease of smallpox. We are all familiar with the story of the milkmaid, but less so with the fact that in the first page of the inquiry, Edward Jenner suggested that the origin of the cowpox was a disease of horses known as grease. We need to keep in mind that those observations were made 80 years before the formulation of the germ theory of disease. So Jenner considered that he was inoculating diseases, not specific viral agents as we know them today. After publishing the inquiry, Edward Jenner continued to favor the possibility that horse grease could also be a preventative of smallpox. But in public, he downplayed that possibility, probably to avoid unnecessary distractions from his main finding. During the 19th century, the inoculation of the cowpox, or vaccination, was used alongside with the inoculation of horsepox, or equination. Among the 23 cases described by Jenner in the inquiry, 5 were linked to cases of horsepox, not to cowpox. And in 1817, Jenner provided equine lymph to the national vaccine establishment. Soon after the publication of the inquiry, other European scientists confirmed that horsepox also protected against smallpox. And Luigi Sacco, known as the Jenner of Italy, even suggested to Jenner to change the name vaccination for equination. Although horsepox was not frequently used in England, there are many recorded situations where horsepox was used to immunize in France. The last well-documented case of equination happened in the Netherlands as late as in 1914. During the 19th century, the cow became the protagonist of the new procedure of vaccination. Remember that the word vaccination derives from vacca, which is Latin for cow. The cow was honored in many medals, as the one shown here that was given by the municipality of Paris to the most dedicated vaccinators of the city. To promote smallpox vaccination in Europe at the beginning of the 20th century, Edward Jenner and the cow became popular heroes, especially in France, as shown in this advertisement card. And the potential role of horsepox fell into oblivion. The generally accepted fact was that cowpox was the vaccine against smallpox. But the science of virology and immunology were progressing. And in 1939, Alan Downey from London published a very important paper comparing 2 strains of cowpox, which, by the way, now we know to be a virus that primarily infects wild rodents in Eurasia. So he compared 2 strains of cowpox with 2 strains of the virus that was used to immunize against smallpox. Using several serological techniques, Downey concluded that the virus causing spontaneous cowpox was not the same as the strains used to vaccinate against smallpox. That observation reopened an old discussion about the true nature of the smallpox vaccine. Since no natural animal host is known for the vaccinia virus, as the smallpox vaccine is referred to, several possibilities were raised. The suggestion that vaccinia could be an attenuated mutant of smallpox or a hybrid between cowpox and smallpox were easily discarded based on the genetic analysis of their genomes. So, three possibilities remain to be investigated. That vaccinia is derived from a naturally occurring orthopox virus now extinct. That vaccinia is a recombinant of different orthopox viruses that may have derived naturally or by manufacturing practices that mix vaccines from different origins. Or, going back to Jenner's suggestion, that vaccinia derives from horsepox. Those hypotheses were carefully considered by the late Derek Baxby, a post-virus expert from Liverpool, who studied the historical record, reaching the conclusion, discussed in a book published in 1981, that a hypothetical horsepox virus could actually be the true origin of vaccinia. Baxby, however, concluded that perhaps we will never be able to know the truth. Horsepox is a rare disease that seemed to have disappeared from Europe early in the 20th century, and that, by the way, was never reported in the Americas. The last case of horsepox ever reported in the world was in 1976 in Mongolia. Fortunately, the virus was isolated and the sequence published in 2006. The phylogenetic analysis of the central conserved region of the horsepox genome revealed that it is closely related to, but different from vaccinia. The authors concluded that while being closely related to vaccinia, the horsepox virus contains additionally potentially ancestral sequences absent in other vaccinia-like viruses. 4 years ago, we decided to investigate the genomic structure of old smallpox vaccines that we found in museums or individual collections. The first one that we examined was a vaccine made in Philadelphia in 1902 by H.K. Mulford, a company that eventually became Merck. We reported that the central region of the genome, which codes for the genes responsible for the replication of the virus, was 97.7% similar to horsepox. However, the genome also has the typical terminal deletions of vaccinia in regions that code genes related to host range, pathogenicity, reactogenicity, and immunogenicity. At that point, we speculated that the use of horsepox as a smallpox vaccine could have led over the years to a gradual loss of selected genes, perhaps evolving into modern vaccinia. This figure shows the phylogenetic tree of the conserved region of several orthopox viruses. The big dotted line, or dotted box, includes viruses belonging to the vaccinia lineage. These vaccines fall into three distinct clades. In blue, the North American dry vax clade. In pink, the horsepox Brazilian clade. And in green, the Eurasian clade. You can see that the old Mulford 1902 vaccine, which is the red dot, maps very closely to horsepox virus, in the same clade that some Brazilian pox viruses, such as Cantagallo. Also note that the cowpox and variola viruses map outside of the vaccinia lineage. However, although the Mulford 1902 vaccine is indeed highly similar to horsepox, it has patches of vaccinia sequence within its genome, even in the conserved regions, which are represented in the slide by the upside-down peaks, which are the regions of less similarity with horsepox virus. This means that the MULFO 1902 vaccine is not a true horsepox that only lack the terminal regions like vaccinia. It is much more complex than that, and we are in the process of identifying the genes that may have been lost or modified in the different all vaccine strains that we are sequencing. This is a preliminary phylogenetic tree of the central conserved region of some, not all, of the all vaccines that we have sequenced. The genomes that we sequence are marked with a red circle. Some of them are true vaccinia viruses, including the earliest vaccinia sequence so far from 1930, made by Sharp and Dunn. The most recent vaccines from the 1970s belong to the Eurasian clade and are related to the Lister strain. However, 3 additional genomes from the beginning of the 20th century are all horsepox-based vaccines, either made in the United States by Mulford or by Park Davis, as well as 1 vaccine made in Colombia around 1939. Very relevant to this discussion is the recent paper by Dugan et al., who sequenced 5 vaccines used in the United States during the time of the Civil War. They all turn out to be horsepox-based. The blue circle indicates where those vaccines map, in the same clade that includes horsepox. And it's important to repeat here that thus far, no new or old smallpox vaccine has ever mapped within any cowpox clade. In conclusion, an analysis of the historical record, together with the genomic sequencing of all smallpox vaccines, supports the concept that horsepox and different horsepox-like viruses were used in the 19th and early 20th century to vaccinate against smallpox. Second, we have no laboratory indication whatsoever of the use of cowpox as a smallpox vaccine. Third, sequence information supports the hypothesis that the different horsepox-like viruses were the most likely ancestors of many old smallpox vaccines, evolving with the loss of genes at the end of their genomes. And fourth, an important shift in sequence happened around 1930 to 1940, when the smallpox vaccines changed from horsepox-like to vaccinia-like, with particular differences in the central conserved region of the genome. This is a work in progress. This work has been made possible not only by the scientific collaborators listed in the slide, but also by the several individuals and institutions that provided invaluable specimens of all vaccines. And of course, we are always waiting and welcome additional specimens for analysis. The work has been partially supported by a grant from the Bill and Melinda Gates Foundation and by other funding agencies that supported the participant laboratories. Many thanks for your attention.
Hello, thanks very much. I'm joining you from the World Health Organization headquarters in Geneva, Switzerland. It's a tremendous pleasure to be here with you. And I look forward to this panel tremendously. It's an honor to be here with those who actually made smallpox eradication happen. As you can see, it's been 40 years since the eradication of smallpox, and WHO has celebrated a number of times over the years at the 30th anniversary. And here we have our co-panelists, Dr. Bill Foege and Dr. Mike Lane. So why did laboratory containment of variola virus become so critical? In fact, when the eradication was celebrated, it was not such a big deal. But as we know, we thought that the last case of naturally occurring variola virus major was this young girl who was infected at the age of a very young age of 3, and she's still alive today in Bangladesh. We thought this last known case of naturally occurring variola minor was in Somalia in 1977, and however, that was not the last case. The last person who actually died of smallpox was a photographer named Janet Parker, who was working above the lab, smallpox lab in Birmingham in the United Kingdom. And in fact, the last case was actually her mother, whose name was Hilda Whitcomb. So these last cases occurred because of a laboratory accident, a laboratory exposure of some kind, laboratory contamination. And Dr. Breman, who's on our panel here today, was in fact part of the investigation, and we hope to hear more. This is where the incident took place. And this is why, following this event, the World Health Assembly mandated the destruction of, first, the consolidation of all remaining stocks of variola virus in a small number of labs, 4, and then eventually 2 at the Centers for Disease Control in the US and Vector in the Russian Federation. And eventually, in 1996, the World Health Assembly mandated the destruction of the remaining stocks. And the reasons for that, given at the time, were that another laboratory accident could happen. This was not acceptable, and that variola virus had clearly been shown to be dangerous in a laboratory context. At the moment, the research that has been since mandated is continuing in 2 very high containment laboratories. We'll hear more about that. But the fact remains that variola virus could still be found in unknown locations, even for countries that did believe that they had in fact moved or destroyed all remaining stocks. Another area of work that has evolved very much over the years is synthetic biology, the advancement of technology in all its forms. And this was a proof of concept of the recreation of an orthopox virus was demonstrated in 2014 with the creation of what had been an extinct horsepox virus. So it has been demonstrated to be possible in a laboratory with available means and some components of DNA that were available for purchase. And so we now know that the risk of synthesis of variola virus will always remain, even though it's not a straightforward proposition. To do it, it is possible. And of course, the thought was, well, what if there's a natural recurrence? So it was thought to be unlikely, that there's no animal reservoir, that smallpox has always been a disease of human-to-human transmission only. But it also is thought that it did evolve from zoonosis in the remote past, and it's not impossible that this could happen again. In fact, we've seen this with COVID-19, and although this is a very different virus, there are concerns that an ecological niche has now been left for other orthopox viruses to fill. And of course, there have long been concerns about deliberate use, intentional harm, and bioterrorism. These were the reasons that the World Health Assembly gave at the 49th meeting for requesting the destruction or mandating the destruction of the remaining stocks. However, very quickly in 1999, there was a request for maintaining these stocks so that research could be done in the face of all these risks. Research could be done to develop medical countermeasures. Of course, we already had vaccine, but there were no treatments. There was some laboratory diagnostics, but of course, a lab diagnosis has advanced incredibly in the intervening period. And so there was, again, an endorsement through the World Health Assembly, the 52nd World Health Assembly in 1999, to continue with development of medical countermeasures. And in fact, this is a program that continues to this day. It's been the subject of much discussion. So let's see, what have we actually achieved during that time? And who's carrying out the work? So the work continues to be carried out in the 2 remaining labs that hold this virus in a very secure environment. That is Centers for Disease Control and Vector. So far, what we have seen is there's now, with advancing technology, full genome sequences available for more than 100 isolates of the variola virus from both units. Nucleic acid-based assays have been developed, and serologic tests have been licensed. Protein-based point-of-care tests remain under development with a range of technologies, and this work is still underway. Vaccines, there's been a lot of work done. Of course, we know there was a vaccine because this is what contributed to the eradication of smallpox in the first place. These are now referred to as first-generation vaccines. And these vaccines are still held in national and global stockpiles. They are regularly tested for potency, of course, because it's been 40 years since their last regular use. However, in that intervening period, another vaccine was developed called ACAM 2000. This is actually the same vaccine, except that instead of being grown in the skin of animals, it's grown in sterile conditions in the lab under controlled conditions. And so incidental contamination or secondary infections are less common with this product, but it has the same safety profile with some fairly rare but important side effects of the vaccine. So the research program continued, and with third-generation vaccines that were developed in Japan with LC16M8 that was licensed already in the 1970s. And since then, the work has continued to seek vaccines with a safer profile. And we now have, since 2013, approved in the in Canada and the European Union, and since 2019, the same vaccine has been approved in the United States of America, developed by Bavarian Nordic, and it's called the Modified Vaccinia Ankara vaccine. It was also, for the first time ever, approved for the prevention of monkeypox. So we also now have a vaccine for the prevention of monkeypox. Work continues to develop other further attenuated, less reactogenic vaccines, and VAC Delta 6 is one example that is being developed in the Russian Federation. So we have a robust profile of vaccines that technically have been advancing, and some of which have been approved and licensed in various jurisdictions. Antivirals is another story. So there has been a robust effort also to develop antivirals, and that was the main purpose for which the World Health Assembly has continued to endorse maintaining this research program. And the first antiviral to be approved against smallpox was in fact approved in July 2018. It's known as tecovirimat as a generic name, and it goes under the commercial name of TPOX. There are other products in development. In 2019, the World Health Assembly endorsed the notion, with some discussion, of course, as every time, that a minimum of 2 antivirals would be recommended in order to avoid the risk of, or at least have another tool to use in the event of development of resistance to the antiviral. So as you can see, there are a number of other products in development, and monoclonal antibodies are also at the early stages of development in both labs. And furthermore, there has been an animal model developed also to help study these products in humanized mice. So the WHO Advisory Committee on Variola Virus Research, which was constituted in 1999, has just had its 22nd meeting last week, in fact, on the 4th and 5th of November 2020, and it continues to monitor and report on the advancement of research on countermeasures for smallpox. However, smallpox is clearly not the only reason. There are many other incidents and events of interest in this area of work. And over the last 2 years, we've seen a few. So, for example, in 2019, there was a cache of decades-old vials, which appeared following a tremendous thunderstorm, and they emerged from the ground in what was a former disposal site, which today obviously would not meet the standards for disposal of vaccine or biological products. These products were labeled Vaccina variolica, which led to the question as to what was actually in there. Of course, it was found to be Vaccinia vaccine, which is what all smallpox vaccines are based on. But at the same time, it remains a biological risk, and laboratory personnel needed to be, in fact, the only laboratory personnel that could work on it were those who had already been vaccinated 40 years prior. More recently this year, there was a broken glass injury in a laboratory, an immunology lab. Someone working with Vaccinia virus had a self-injury, self-inoculation. The researcher was younger and had not been vaccinated. And antiviral treatment, tecovirimat, was in fact procured internationally on a one-off basis with special approval of the government in question. These incidents are not uncommon. Many are reported and published in the literature, but just to show that they do continue. And in general, vaccines are not available for these laboratory personnel. Also recently, we'll hear more about this later, a new second only ever described human case of a new orthopox virus, which has been named Alaska pox, was found, of course, in Alaska this year. And another area of work which is really evolving rapidly is the area of paleogenomics and discovery and sequencing of DNA from museum specimens and ancient human remains. And this is an example. Variola virus genome sequenced from an 18th century museum specimen supports the recent origin of smallpox. So this work on the evolution of the virus remains of interest. It helps us understand viruses today and provides insight into the pathogenic mechanisms of certainly orthopox viruses and smallpox in particular. So this is an area of concern, of a major public health concern, I would say, which is the emerging pathogen monkeypox. It has been described for many years now, and since it was first described in 1978, human monkeypox has continued to emerge in the Democratic Republic of the Congo, with we're on track for over 7,000 cases to be reported in 2020 so far. And of course, this is now filling an ecological niche because now generations of people have not been vaccinated against smallpox. And so that vaccine was also protecting against monkeypox and had been known to be effective against monkeypox. So this is now an area of significant emerging concern. You'll hear more about it later, so I won't go into it more here. There was an outbreak in Nigeria in 2017 of several hundred cases, from which cases had been exported to the United Kingdom and Israel, with one secondary case in the UK and Singapore in 2019. So WHO is developing a training program which is accessible on openwho.org, which is our training platform. So what have we achieved then? What is the public health benefit, and what are the remaining challenges of medical countermeasures? So clearly for diagnostics, we have developed assays for orthopox viruses or specific to smallpox, monkeypox, and others. It's a tremendous area of research, and the work needs to constantly be adapted to new and evolving platforms. However, these laboratory assays are not necessarily available yet everywhere, and point-of-care tests are not available. So making now these technological advances available for public health benefit remains the challenge basically for all of these. For vaccines, national stockpiles and global stockpile that we have do offer some health security. But again, quantity is probably may not be sufficient, and the vaccine there remains a mix of the first generation vaccines that are decades old and a much smaller quantity of the newer vaccines. So MVABN is the one I mentioned, is the first vaccine which has been approved for monkeypox, but these vaccines are at the moment not available for laboratory personnel, and this is an area of work going forward. Antivirals, we've seen that we do have antivirals approved, one antiviral approved. Of course, it's never been used for a case of smallpox because we haven't had a case of smallpox, thank goodness. But we are now seeing off-label use on special occasions and special events for vaccinia and monkeypox exposure or infections. And again, these agents are not yet widely available. So in summary, smallpox research has yielded a broad range of countermeasures of public health benefit, which continue to demonstrate their interest which is in fact the reason that the research program was maintained in the first place by the World Health Assembly. And however, these countermeasures remain to be made more widely available for health security and emerging infectious diseases. So what's next for the variola virus at the World Health Assembly? Well, you may know that we are right now, the 73rd World Health Assembly is taking place in the part two. The first part was in April and was only discussing COVID-19. Now we have part two underway, and there will not be a substantive discussion. There's been a report presented on smallpox and the research to date for this assembly. The next substantive discussion will take place in 2023 or 2024. And by which time we expect to have another antiviral against smallpox. So what we've learned over the past few decades are that risks of reemergence of smallpox have in fact increased, not due to laboratory concerns as in the past, but in fact due to synthetic biology, advancing technology in synthetic biology. And diagnostics and vaccines have been developed as planned, and we do expect to have 2 antiviral agents. However, the benefits are yet to be made available to most countries. And so the big question is, will WHO member states abide by resolution of the World Health Assembly 4910, which was to ensure the destruction of remaining stocks of variola virus in our 2 collaborating center repository sites? Or will the COVID-19 pandemic or the other changes that have really happened over the last 40 years lead to a rethink. This is, of course, the remit of the member states. And we will see at the next discussion. Thank you very much.
Today I'm going to talk about monkeypox surveillance and control in Central Africa. Monkeypox is a re-emerging zoonotic infectious disease which is enzootic in Western and Central Africa, with overwhelming majority of human infections reported each year from the forested areas of the Congo Basin, and in particular in the Democratic Republic of the Congo. It's a zoonotic orthopox virus that can cause serious smallpox-like illness in humans. And in fact, the first human monkeypox case was identified in the Democratic Republic of the Congo in 1970 in an infant that presented with smallpox-like illness. And this was in the context of the Smallpox Eradication campaign, when smallpox cases were decreasing and every case was investigated. Right now, the reservoir species is still unclear. However, squirrels and other rodent species have been implicated in transmission. Since 1970, when the first case was discovered in a human, cases have been discovered throughout Africa, West and Central Africa, but the true geographic range of this disease is yet to be determined. But it does likely coincide with natural range of reservoir species. Over the years, we've seen monkeypox cases reported sporadically throughout West and Central Africa. But, and prior to 2000, there were very few cases reported outside the Democratic Republic of the Congo. But in the last several years, we've seen an increase in cases, especially since 2010, including cases in the Central African Republic, Sierra Leone, Liberia, and most recently in Nigeria. This slide here shows the number of cases that have been reported throughout Central and West Africa over time. We can see here that the Democratic Republic of the Congo has the vast majority of cases reported, but there are increasingly cases reported elsewhere. I happen to work in the Democratic Republic of the Congo, where we have been working on monkeypox for many years. So I can tell you about surveillance of monkeypox in this setting. Monkeypox is a nationally reportable disease in the Democratic Republic of the Congo and has been identified as one of the disease priorities of epidemic potential and is reported regularly in DRC. This slide here shows the trajectory of reported cases in DRC over time up through 2019. And it's clear, you can see a rise in the number of cases very clearly over time. We first started looking at this phenomenon of the increase in cases of monkeypox back when in my early work in DRC, and published a paper on this in 2010 in the Proceedings of the National Academy of Sciences, where we documented a major increase in the incidence of monkeypox 30 years after smallpox vaccination campaigns ceased. And what we found was a per capita increase by a factor of 20 between the surveillance program of 1981 to 1986 and our surveillance program in 2005 to 2007. And this really was a study that showed that it looked like this increase was likely due to waning immunity to smallpox vaccination. We did some work with my colleague Jamie Lloyd-Smith, looking at age distribution of the monkeypox infections back in 2000 or in the 1981 to 86. And our current data. And what it showed was that smallpox vaccine was still likely to provide about 82% protection against clinical monkeypox infection, suggesting that there was no significant decline over time. This was important. Of course, the big question when we see all of this rise in monkeypox cases is, are the increases a true increase? Is it just increased reporting, or is there something else going on? Of course, compared to the 2000s, the early surveillance data in the 1980s, they had more, it was more resources, there was more funding, more incentives to the population. This slide here shows you a picture of a poster that was used in these monkeypox, in monkeypox investigation in the Democratic Republic of the Congo, where they were giving rewards to people reporting monkeypox. And at that time, this 500 Zaires was equivalent to $90 US. So you can see here that there was a lot of impetus to be able to report monkeypox. So, you know, that increase that we saw between the 1980s and the early 2000s is very likely to be real because there was a much better surveillance system in place. There was a lot of incentive for reporting monkeypox that we don't have today. And so what we can conclude is that it's very likely that this increase is real, this 20-fold rise. And we've, since that time, seen additional cases. And the idea that smallpox vaccination would be protective, that we have an age distribution now where the vast majority of the population no longer has immunity to smallpox makes sense. So we do believe that these increases are in fact real and not an artifact of just reporting. Control strategies for human monkeypox against this background of increasing caseload calls for really rethinking control strategies, in particular in Central and West Africa. Of course, control strategies include behavioral interventions, vaccination strategies, now that we do have a vaccine that may be available that could be used in high-risk populations, including healthcare workers. But really, the backbone of improving control strategies for human monkeypox means improving surveillance systems, increasing laboratory capacity, and providing high-quality training for healthcare workers so that they can identify any suspected case of monkeypox easily and be able to get it into the system for investigation as quickly as possible. There are many challenges to responding to this increasing number of monkeypox cases and emergence throughout Central and West Africa. Of course, we have suboptimal disease surveillance systems. We know that disease surveillance is stretched in many of these cases that fall into the range of where monkeypox could be, in particular in Central Africa. And this is compounded by a lack of monkeypox knowledge, including at a national level. Also, when you do find a case of monkeypox, often the healthcare workers may not have appropriate knowledge of the right kind of specimen collection or have the materials to be able to collect samples appropriately. And then the logistics of shipping those samples back can become very complicated. In most countries, there are not good animal surveillance ongoing, looking for doing serosurveys, really understanding the potential for reservoir species in these areas. Laboratories are limited in their ability to test for monkeypox. Another issue is we have a lot of population movement across and between borders. So for example, DRC is on borders the Republic of Congo, Uganda, and borders 9 different countries. And so understanding what's going on in one country and importation of cases either direction is very, very important. We've seen this with the Republic of Congo, in fact, and cases that have been imported from DRC to the Republic of Congo. There are limited trained personnel. And then when somebody does have monkeypox, the knowledge of how to treat this case and how we can use isolation facilities, appropriate PPE, all of this is very difficult. The stigmatization of monkeypox cases is also very important. If people are afraid of reporting cases or identifying a case of monkeypox because of potential stigmatization, it means that reporting is going to be difficult. A big problem that we face in the Democratic Republic of the Congo, and certainly in other countries as well, is that we really do have to rely on non-governmental organizations or the polio program for ad hoc surveillance and response, which means that we don't have standardized activities. Another problem is that most cases of monkeypox occur in geographically remote areas, which can make it very difficult to be able to respond to these cases. And in many places where monkeypox occurs, including places like the Central African Republic, civil conflict and insecurity has definitely hampered good response. I just want to talk a little bit about some of the challenges for monkeypox specifically in terms of epidemiology and surveillance. Monkeypox is not systematically in all countries that are enzootic, but even surrounding countries around that, monkeypox is not systematically incorporated into the Integrated Disease Surveillance and Response System, the IDSR system. And that's a really important way to be able to keep track systematically of what's going on. Data management and historical record keeping of case investigation forms from monkeypox cases is also limited, which also makes it difficult to go back and really understand what's going on. There's limited resources for case investigation and outbreak investigations. Case definitions are not standardized. There's a lack of knowledge regarding monkeypox in many of these countries. Specimens might not be collected appropriately. And many samples are just being collected in the context of research studies as opposed to a big systematic surveillance system. And that can make it very difficult because these research results are not always synced up well with the systems, with the surveillance systems. Finally, there's no systematic way of alerting neighboring countries of confirmed monkeypox cases and really, dealing with these border issues. Given the complexity of epidemiologic surveillance and the fact that surveillance is difficult under the best of circumstances, we have some recommendations for improving it. Developing standard field manuals and toolkits would be very important. Standardizing training for healthcare workers in endemic countries and in countries that are surrounding endemic countries, because we know that we can have imported cases. Of course, including monkeypox in the IDSR would be really great. Strengthening data management systems, building mechanisms for cross-border movement and communication and information is key. Strengthening One Health approaches to investigation of monkeypox cases would be critical, and supporting each endemic country to have a monkeypox disease control and outbreak response plan would go a long way towards improving surveillance. Of course, I do want to highlight the importance of case definitions and really good training. Monkeypox is often confused with chickenpox, and in this slide here, you can see that that we have several different pictures, mostly of monkeypox, but down here in the left-hand corner, that's varicella. And so you can see that it would be very confusing for many healthcare workers to be able to keep track of whether or not this is monkeypox or chickenpox. But I also do want to point out that there are other diseases that could also be confused for monkeypox, and that also includes drug eruptions, syphilis, scabies, rickettsial pox, herpetic infections. So there are many things that could also be that could be confused with monkeypox, and that's why good case definitions are very important. There are many challenges to laboratory diagnosis of monkeypox as well. And I just want to highlight that what we discussed earlier, inadequate sample collection is important, but also inadequate reagent supplies and just general supplies and supplies in general can be problematic. Timely receipt of specimens does impact quality of the analysis as well, and often samples are sent without the requisite case report forms and data, which then can make it very difficult to really understand what it means. The other thing that's really problematic is if you have a case of monkeypox in a place that doesn't have the ability to do the lab work, if you don't already have the memorandums of understanding in place, the MTAs in place, and other formal agreements in place, it can make it very difficult to get samples between countries for testing. And we've seen this in the past where one country may not have the capacity, but a neighboring country does, and you really need to be able to work these things out early on, so that we can respond quickly and get good diagnostics happening fast. It's really an issue for laboratory as well as for surveillance. It's really important just to be thinking about the fact that failure to prepare is going to mean failure to be able to respond. So the recommendations based on these issues that have been identified are making sure that we have really good training in place, not just for the healthcare workers in terms of being able to investigate the case, but also in sample collection, data collection, and really knowing what that pathway is going to be getting to get those samples to a laboratory. And integrating laboratories and surveillance systems well so that they are integrated and that the information is flowing appropriately so you have rapid detection and case confirmation as soon as possible. It's really important also to make sure that all of this is happening with good understanding of what's going to happen if you have to send samples outside of a country if needed and what that looks like. Having reference laboratories designated nationally and regionally is important, but again, you need to have all the agreements in place and be ready to move quickly. And then really strengthening use and training of diagnostic capacity in endemic areas is critical. So with this in mind, I think it's just important to really think about what the lessons learned are to date about surveillance and control of monkeypox. And the first thing is that accurate disease surveillance is really critical, but especially where it's most difficult. And I always use this slide. I've been using this slide for a very long time, but it's still true today. You know, there's a true number of cases out there, but only a fraction of those are actually reported to a health system. And of those reported to a health system, only a fraction are investigated. Only a fraction of those have lab samples collected. Only a certain number of those are actually viable when they get to the laboratory. And so really the true number of cases is likely to be much greater than what we actually see. Infrastructure is going to be really important. Government ownership is really important, and international collaboration and cooperation is critical here. It's also important to remember that monkeypox surveillance depends upon having really good information and understanding geographically where things are and how you are actually, and how that relates to other places. You know, I work in the Democratic Republic of the Congo, and this slide here is really demonstrating the importance of good mapping. I have here in one corner a typical hand-drawn map from a health zone. But the thing is that these hand-drawn maps don't always correspond perfectly to the reality on the ground. And so it's really important to have the best mapping data and be really ready to understand where things are in context. Another thing I want to really highlight here is it's important to remember that eradicating a pathogen, such as smallpox, does leave the door open for similar pathogens to fill the void, and surveillance needs to be ready for that. So it's not just about detecting monkeypox, but other pox viruses, and having good surveillance for rash illness that is unusual is critical here. This slide here just demonstrates all of the other pox viruses that have now been detected. And in recent years, we're seeing more and more cases. For example, camelpox in India, and very recently, Alaska pox in the United States. You know, as we see the immunity to pox viruses waning, it only makes sense that as we continue to be exposed, we're going to be seeing more pox viruses now that the world is no longer vaccinated against smallpox. All of this in mind, we want to just think clearly about what's next. We have to improve monkeypox surveillance. We need to be able to use those data for good control measures, but we also need to have good operational research ongoing at the same time. There's still a lot of questions out there that need to be answered. And all of these questions will feed back into better control measures and better ability to do good disease surveillance. Thank you very much for your time, and I've enjoyed being able to give this presentation.
Good morning, colleagues. Today we're going to present some work done at the Nigeria Center for Disease Control on the re-emergence of monkeypox in Nigeria in 2017 and what has happened since then, since its re-emergence in Nigeria. My name is Chikwe Ihekwazu. I lead the Nigeria Center for Disease Control at the moment. So a bit of background about Nigeria. It's important for this outbreak. So even if some of you know a lot of this already, it's a country of 200 million people. So a lot of people living in a defined area, a growing population, growing at about 3%, just under 3% per annum, has one of the highest population densities in Africa, which is an ideal situation for the transmission of infectious diseases. We have a big challenge around our socioeconomic conditions, a lot of people living in poverty, climatic conditions, and all of that really come together to provide an ideal environment for the transmission of infectious diseases. Having said that, we're working very hard to prevent this, working to build a health security architecture across the country. Our last joint external evaluation gave a score of 46. We're trying to improve this every day in Nigeria. We've been faced with many big outbreaks over the last few years, from Lassa to monkeypox, which I'll be talking about, meningitis, and the COVID-19 pandemic, which we're dealing with right now as a global community. So that provides some background about Nigeria. The big outbreaks we've had to face include the Ebola outbreak in 2014 that everyone remembers, and Nigeria did get a lot of acclaim for its very bold strategic response to that. So it did not end up being the doomsday many people thought it would be. If we were to have Ebola in a city like Lagos, where it actually did happen, we're able to contain that fairly effectively and prevent a big outbreak in Nigeria. In 2016, we were on the verge of elimination, and then we saw the re-emergence or emergence of 4 cases of the wild polio vaccine in Borno State. Borno, has had a challenge of significant insecurity for many, many years, which of course has its impact on every aspect of life, including surveillance and detection activities. So we had to respond to that. That set us back 3 years, and we've just been able to be declare Nigeria and the continent free of wild polio virus this year. So we lost 3.5 years to that challenging situation. We had the biggest outbreak of cerebrospinal meningitis that we've had in many years, also in 2017. And that year also saw the re-emergence of monkeypox in Nigeria. I'll describe monkeypox in a bit more detail in subsequent slides, but just to say, recurrent every year over the past 4 years, we've found more cases of Lassa fever than the previous year, and every year has been the largest outbreak of Lassa fever ever. So really, we're a country that is challenged with the spread, transmission of infectious disease, and we need to develop the capacity to do so, which is exactly what the Nigeria Center for Disease Control has been set up to do. So it's a fairly young center. We're set up in 3 campuses, 2 in Abuja, 1 in Lagos, where it all started for us. We have a very clear mandate to lead on the prevention, detection, and control of communicable disease in Nigeria. Strategically, that's the mandate, legal mandate passed by an act of parliament that we have to coordinate surveillance systems, support states. It's a federal republic, so we have to work very closely with states. So our mandate is to support the states in responding to small outbreaks, and then lead the response like we've done for large national outbreaks like the COVID-19 outbreak going on at the moment. We're also required to maintain a network of public health laboratories across the country and to synthesize public health research for decision making. This is important because it provides a context for the next few slides that I'm going to share on the emergence and response to monkeypox in Nigeria and the role NCDC played in all of that. So to set the scene, we've described the Nigerian population, the challenges of our socioeconomic realities, our population size, density, and all of that. In addition to the emergence of this National Public Health Institute with a mandate in the context of many competing requirements for resources in Nigeria to respond to this series of challenges. So late in 2017, we got an alert of a strange illness in Bayelsa State, in the heart of the Niger Delta, in the oil-rich region of Nigeria, with cases with this strange illness that was ultimately classified as monkeypox. We hadn't seen this in many, many years in Nigeria, and I hadn't seen any case in my medical training, and no one I knew had. So it was a very steep learning curve as we learned about this new disease and tried to decipher what to do, how to define it, how to confirm that this is monkeypox. Everyone was quickly reading up whatever literature there was to define this new cluster of cases. There was a lot of anxiety in Nigeria among our political leadership, in the press, and really anxious about this disease that really looked very frightening when you see patients. So the first case was reported in September 2017 in an 11-year-old male patient in Bayelsa. Of course, you can imagine with a case like this, he would have been histories would have been taken several times over, trying to identify a source of infection in him. The only potential contact was actually contact with pet monkeys. And like we know, even though the name of the disease is monkeypox, there's very little relationship between monkeys and the disease. So, this was kind of, we weren't sure whether it was a red herring or not, but we continue to find new cases. Once people became aware of this new disease, and we sent out the case definition and a few images of what to use to find cases. New cases were reported almost on a daily basis from various aspects of the country, especially in those riverine areas around the Niger Delta. Like I said previously, we hadn't seen any cases since the early 70s. And in the 70s, in the literature, there are a few cases reported, one in 1971, two in 1978 previously. These were isolated cases reported in the literature. And since then, either through our public health surveillance or through public literature reviews, there hadn't been any cases reported in Nigeria since then. So very surprising for us to find this outbreak. And we've continued to find cases since then. These graphs just show the epidemiology of monkeypox in Nigeria from 2017 to date. You see the peak in 2017. That really describes the cluster of cases we found at the time. Then the rest are yearly curves. You see a trickle of cases every single month. Since then, we've now found over 450 suspected cases, of which 190 have been confirmed. We've had 10 deaths. We need to do some more detailed analysis to see whether all of them actually died of monkeypox or of some coexisting morbidities. HIV seems to be frequent finding in those that were ultimately diagnosed with monkeypox. So we're still trying to disentangle that. We found cases almost in 18 states in Nigeria, so quite widespread, and cases have had an age range of 2 days. It was our youngest case to 69 days. You can see from the chart there's a preponderance of cases in males. So that's really a summary of the epidemiology of monkeypox since detection of its re-emergence in 2017. So on slide 9, just shows a few images of from patients. You can see the skin lesions on the soles, palms, on the feet, on the face, of many cases. So, you know, these are very severely affected cases. But we've also seen patients with one spot here or there that might not be as obvious as the images on this picture. But we've now have a good collection of images of cases of monkeypox in Nigeria. We did some more detailed analysis of the first cluster, including both epidemiological analysis and genetic sequencing of the viruses found in patients in that cluster. And some interesting findings. You know, we found that the viruses circulating in Nigeria were similar to those circulating in Nigeria in the 70s. So you can see the gray patients with the gray dots. Those were patients, those were sequences from patients in Nigeria in the 70s. And you can see a very close genetic similarity to the cluster of cases found in 2017. But we also saw that the cases in 2017 were sufficiently dissimilar from each other genetically for us to come to the conclusion that there appeared to be multiple primary infections or transmissions from whatever the zoonotic host is to humans in 2017. So very interesting finding. So these were all sufficiently dissimilar from each other for us to come to the conclusion that there were multiple primary viral introductions into the human population. But we did find some human-to-human transmission that happened in the light pink area of cases that where we think human-to-human transmission happened, and this was in a specific clinical cluster. And you can see the arrows here point where we have both epi and genetic data to reach our conclusion of transmission within a cluster of human-to-human transmission. And I think the green arrow shows where it's only epidemiological data available. So very interesting and very varied conclusions coming in here of local human-to-human transmission, independent primary introductions, and a link to the historical cases in Nigeria previously. So what are our conclusions from that outbreak? We haven't been able to identify a primary animal reservoir. We've been trying the ongoing surveys of potential host animals going on. This COVID-19 pandemic has interrupted some of that work, but we continue to try and we'll restart this. We started last year with some sampling. Less than 10% of our cases actually have any known history of contact with any animal within the incubation and pre-incubation within the pre-incubation period. So really a lot of food for thought. And in the preliminary findings of the animal survey that we conducted showed the presence of anti-orthopox antibodies in only two of, I think, hundreds of small animals that were captured and tested. The secondary human-to-human transmission that we found was mostly in a prison cluster, so among people that were together in a prison in one of the cities in southern Nigeria, some in healthcare workers, and a few in household contacts. So these were the contexts for which human-to-human transmission happened. And then we had the unfortunate situation of exporters of monkeypox to a few other countries. two to the UK, and then there was one local transmission of monkeypox that then happened to a healthcare worker in the United Kingdom. One case in Israel and one case in Singapore, all of whom are most likely to have had been infected in Nigeria from their travel history. And we've just published a paper demonstrating this, actually linking all those cases in travelers to most likely transmission in Nigeria through genetic sequencing that linked those cases. So we can very quickly see how this particular case demonstrated the global risk of transmission of infectious diseases, albeit with something like monkeypox. A few years ago, if we had learned quickly enough, we may have learned lessons that might have been relevant for our COVID-19 response. But this is actually, we're fairly lucky that this was with a disease that's not very efficiently transmitted, actually, from person to person. So, in summary, what were our response activities to monkeypox? We set up national, state-level emergency operation centers to coordinate the public health response to in places where we had cases. We established One Health rapid response teams, recognizing the important role colleagues in the animal sector had to play in the investigation and response to this outbreak. And this really brought us much closer together with people working on the animal health side. We set up testing capacity within 3 weeks at the Nigeria Center for Disease Control, our national reference lab. This was with support of the US Centers for Disease Control. We, at the beginning, like I said, we didn't know much about monkeypox, had no national guidelines, so we had to scratch around for whatever support we could find. But we've learned a lot in the last few years and published national guidelines to support the response to monkeypox that are now being used in Nigeria, but have been actually adapted by many other countries and are contributing to new guidelines being developed by the World Health Organization. We quickly set up very clear public health messaging through risk communication efforts, and set up using that supported the case-based surveillance and active case search, looking for new cases in the country. We also use the Delphi process to make a critical decision on whether to include monkeypox within our IDSR, Integrated Disease Surveillance and Response Strategy, and made that decision. So monkeypox is now one of the cases that for which surveillance goes on a case-based surveillance basis, so very important, and that's why we now have a fairly robust data for the last few years on monkeypox in Nigeria. These are a few papers that we've published both on the initial outbreak. There was an initial alert as well describing the genetic sequencing, and one we've just done on the clinical course and outcome of monkeypox in Nigeria. And the most recent paper published is actually not on this slide, which brings together the experiences of the cases in Singapore, in the UK, and in Israel, linking it to the cluster of cases in Nigeria. So we're continuously contributing the global knowledge of this disease, and ultimately hope that this will inspire a global response. So from where we were, from having no surveillance in place in 2017, no laboratory diagnostic capacity at all, to where we are today, have a collection of people that have both clinical and public health expertise in the relevant areas of infection prevention and control, surveillance, laboratory diagnosis relevant for the control of monkeypox. We've built up a surveillance approach for monkeypox, integrating it into our integrated disease surveillance and response architecture. We've set up laboratory diagnostic capacity and planning to expand this further so we can bring testing closer to locations where cases are more likely to happen. Together with partners both in Nigeria and in the US, we're now routinely sequencing our viruses to also establish genomic similarity between the viruses that we find in Nigeria and have developed significant expertise in the clinical management of this disease. So to start concluding, monkeypox is sadly not a priority in most countries. There's limited surveillance in animals, very poor knowledge of the disease, and really lack of understanding of what the true burden of this disease is, and very little investment in diagnostic capacity, both using platform approaches or specific PCR for monkeypox, in terms of developing this capacity beyond where it was over the last 20, 30 years. So really challenging situation across board in our ability to prevent, detect, and respond. But that hasn't stopped us from trying and developing that expertise and contributing to knowledge. So we think that through our efforts, monkeypox is no longer a rare disease and really requires concerted global efforts. We need to incorporate monkeypox into our surveillance systems in West and Central African countries. We don't think this is as rare as people thought it was. We need increased knowledge of this disease, and we can do that. We're contributing to that from the Nigerian end, but we really need a little bit more focus on this globally, developing regional surveillance guidelines for monkeypox, and investing critically on research that will help improve current knowledge of disease and ultimately help us develop effective response.
Yeah.
Thank you very much to all the presenters on this panel. Before we go any further, though, I'd like to ask Joel Breman to give us a few of his thoughts about the discussion in the panel, and also to ask any questions. So Joel, over to you.
Before we go any further, though,
Thank you, David. 2 years ago at the Society's meeting, we had headlined on our abstract book, "There Will Be Epidemics." And I think that truth has come through loud and clear with COVID. But I remind you that as we are speaking, there are percolating in places that we've heard spoken about today and in other areas of the world, other microbes that are coming to the fore, and we have to be ready to deal with them. Dr. Foege mentioned that the best decisions come from the best science, and the best results come from the best management. So my first question relates to the concept of management. And I'm going to throw out a few questions, and Bill, you might talk about management in science and public health and how those results have come to the fore with people and resources. Next, I'm going to go to the last few speakers on monkeypox. We haven't heard what criteria are used in Nigeria, DR Congo, and at WHO regarding reinstitution of vaccination in areas where monkeypox cases are exploding and the population is effectively no longer immunized, certainly those born after the 1970s and early 1980s. So surveillance, of course, is the key, and eternal vigilance is the price of liberty, and we will have new orthopoxviruses. So I'm going to leave that and throw the floor open to the last speakers and then to Dr. Foege.
I do have comments about synthetic biology as Jose Esparza presented and what the chances are of synthesizing variola virus and creating a new peril. And of course, this relates to Rosamund's comments about destruction of variola virus, which the World Health Assembly has not yet concluded. Certainly the virus in laboratories is a greater peril than anything else. And the countries of the world in the 80s voted to destroy these strains, and there has been a delay in that. So let me open it to the countries, to Doctors Chikwe and Annie Rimoin to discuss the criteria they would use to revaccinate.
You go first.
Okay, so I think that in terms of criteria for revaccinating, you really have to think about what is possible that the health system can bear, right? Because we already have a situation in a place like DRC where we have vaccination rates so low that it is, and the barriers to vaccination are so great. Adding this vaccine and coming up with opportunity to do vaccination campaigns is definitely something that will add burden to the health system. So what I would say is that looking at the most vulnerable groups like healthcare workers and people who are at the animal-human interface, doing targeted vaccination in those groups would be the way that I would suggest moving forward if we were to be vaccinating. Certainly healthcare workers in areas where we know that monkeypox circulate would be a first group to consider strongly. But then hunters, abattoir workers, people who are truly at this animal-human interface regularly would be good groups to consider as well.
Chikwe, you consider this?
Yeah, very, I could say almost the same thing for Nigeria, but in addition, there's just so much we don't know yet on this disease and why it circulates. It appeared from nowhere a few years ago. We had this significant cluster with widespread cluster in Nigeria, and then it seems to have disappeared almost. We find a trickle of cases every month, but not really in the numbers we thought would happen after the first outbreak. So I think the first thing is to really focus on the science, like we've learned so well this session, to try and really develop our understanding of this virus, potential cross-immunity with other orthopox viruses, or what has led to, firstly, its re-emergence, and secondly, almost disappearance from the scene. But what we're trying to do in Nigeria is strengthen the surveillance system to really try and understand it a bit more and do some enhanced surveillance in specific areas where we had more cases. So just to conclude on the vaccine part, there are two issues. Firstly, we don't understand the size of the problem. Also, there's a challenge around the perception of the size of the problem. So firstly, the reality. Secondly, the perception around it. And obviously, we may not be as challenged as the DRC in terms of vaccine distribution, but we definitely have our own challenges as well in that regard.
WHO, is there guidance? Do you have an algorithm, or is someone looking at the issue of when vaccination would be recommended for these populations at high risk? The country's
yes.
deciding, of course.
Well, it's a really good question, and it's really an important question. There are many barriers yet to this proposal coming to fruition. So yes, there is guidance. So far in 2013, the SAGE, Strategic Advisory Group of Experts on Immunization, did provide guidance on this. And at that time, there was, I think the ACAM 2000 had come out, but there was really, the Bavarian Nordic vaccine was only just becoming available. And at that time, the SAGE did recommend that vaccine be reserved for those at highest risk, and specifically mentioning laboratory personnel. Now, 7 years later, we do now have a licensed monkeypox vaccine, which is the Bavarian Nordic vaccine, which goes under different names. It goes under the name of Jynneos in the US, Imvanex in the European Union, Imvamune in Canada. And this vaccine, however, is still available only for stockpiling and in small, well, relatively small quantities, insofar as it's not available on in the private sector, on the commercial market. Even laboratory personnel cannot yet purchase this vaccine. So it's not pre-qualified, it's not available yet. It's going into national stockpiles. So there's a lot of work still to be done. And with our first step at WHO will be to go back to the SAGE and say, well, we now have more smallpox vaccines. They're deemed to be safer. There's a couple more in the pipeline. We have a monkeypox vaccine. And what is the advice that we can give, certainly for laboratory personnel, but also frontline healthcare workers and others? And the other thing that I would add from an epidemiological and public health perspective is, as Dr. Chikwe says, is that we don't yet fully understand the scope of the problem. And so surveillance and confirmation of the pathogen when it could be measles, chickenpox, anything else. So we really do need better laboratory capacity in the countries affected, better surveillance in the country. Everybody's working hard on that, but of course more work can be done. And then perhaps vaccine could be used for very limited outbreak response if there seems to be extensive person-to-person transmission. Right now it's primarily zoonotic disease. And so that leap to vaccinating everyone is probably a leap too far right now, but a lot of questions yet to be answered.
Thank you very much. David, I don't know how much more time we have, but I would like to ask Jose whether the synthesis of horsepox and polio de novo bodes ill for devious either groups or nations to resynthesize variola and have that pose a risk to the world. That's, of course, one of the bases upon which participants in the WHO discussion have voted against or deferring the destruction of the virus in laboratories. So, Jose, do you want to comment a bit on synthetic biology and the ability of others to recreate the dangerous pathogen that we've talked about today?
Sure, Joe. I want to say first that we are not doing synthetic biology. I mean, the vaccines that we have studied using modern sequencing techniques are highly degraded, the virus in the vaccines, and we have actually tried to cultivate some of these viruses, and we cannot cultivate all vaccines because they are totally degraded. Now, the synthetic biology capabilities are out there. You mentioned polio, the work of Eckhard Wimmer. Remember, he published in Science to show that he could purchase nucleotides and recreate the poliovirus. The same is true with orthopoxviruses and with many other viruses that have been recreated by synthetic biology. So this is a reality, and we'll need to be aware that that can be done. It's not trivial, my understanding. I am not a synthetic biologist. My understanding is not trivial to do it, but it can be done. So we need to be aware of that.
Thank you. And Bill, you'll have the last word here regarding the importance of management and how would that be applied, or at least what is the training that we need for managers of these global programs. In the past, up until smallpox, in my knowledge, that management had not been given the equal reign or recognition or incentives as science and even public health.
Thank you, Joel. First, I'm impressed by how much knowledge has come just since smallpox eradication, both going backwards to tell us about the vaccine, but forward with monkeypox and what's happening in the field and what's happening in the lab. This is very impressive. I think traditionally, our schools have been focused on philosophy, skills, and knowledge. Nowadays, it is so and at that time, most of the time was really on the transmission of
David,
knowledge.
I've got to leave you. Thanking everybody. I'm going to a COVID session that I am co-chairing now. So continue, Bill. This is to be continued in rhyme, in prose, and poetry that David will be coordinating. Thank you all, guys. It's been marvelous. Continue, Bill. Excuse me.
Thanks, Joel. I was just saying that traditionally we spend most of our time in training in knowledge transmission. But now when it's so easy for all of us to get knowledge by going to the internet, we should be spending more time, I think, on skills. And the two skills that we're really deficient in are management skills and the political science skills. The American Management Association has for years put on a great course where you run a company by means of computer, and you can compare your return on invested capital with everyone that's ever taken this course. We should be having the same thing in public health. And the return on invested capital turns out to be the reduction in unnecessary suffering, the reduction in premature death. So I'm impressed, and I think we could now be changing a little bit. I think the lesson of smallpox eradication really turns out to be it is possible to get the entire globe to agree on something. It's not only possible, it's absolutely necessary to do that. And the gift of smallpox eradication is that traditionally we are borrowing things from our grandchildren that they have to repay. With eradication, you are actually making a contribution, a gift to the future. And it's not just a gift of reduction in disease, but the United States recoups its total investment on smallpox eradication every 3 months. I mean, think of that. The benefits just continue to accrue. The investments have stopped. Every 3 months, it means the United States, because it doesn't have to do quarantine, because it doesn't have to treat people who have the problems with the vaccine, the adverse effects, these sorts of things. We save every 3 months, and we now save every year as much money as our total dues to WHO. I mean, think of that comparison. So this should make us bolder to try to get bigger projects in the future. And I was just saying yesterday in a panel, the three big things that have changed in global health during the last few decades. Number one, we see what happens if politicians get involved, and President Carter was able to demonstrate this. I can go to a country in Africa and see the Minister of Health, but I can't see the head of state. Carter could see the head of state, and once he got the head of state interested in guinea worm in Nigeria and so forth, you know the minister became interested. The second big change was with the Bill and Melinda Gates Foundation making global health a respected area for research, for conducting activities and so forth. And the third biggest one was getting corporations involved. And so we like to denigrate corporations that all they're interested in is the bottom line of profit. But when you look at what Merck has done with Mectizan, and now something in the neighborhood of 1.5 billion free treatments that they've given over the years, these three things are very important. And none of them would have happened without smallpox eradication. So this is a legacy that will go on into the future, and I appreciate the chance for us to appear on this celebration. Thank you.
Thanks very much, Bill, and thanks to all our other panelists for a very interesting session. And we'll now sign off.
Thanks to everybody. What a pleasure.
Great to have seen you all.
Thank you. And thank you for convening and coordinating the panel, David and Joel.
Yeah.